Welcome to the Elizabeth McGowan Training Institute at Morningside Ministry. mmlearn.org's distance learning is proud to offer a 4-module series dealing with behavior problems, dementia, and mental illness in long-term care. These modules are going to address skilled nursing, assisted living, and in some instances you'll even see it applies to residents we serve in independent living. The presenter we're delighted to have is Dr. David Smith, a geriatrician, certified medical director, and author on this subject. And most important to you, he's a great speaker. He's going to hold your attention and bring incredible examples, and he leaves you knowing that he knows what you are dealing with. That's most important. The first module deals with behaviors in dementia, the causes, identifying problems as they relate to admissions, MDS, change of condition. You're going to learn the possible etiologies or causes of dementia and those conditions that might just be masquerading that we can better address. Very important, very interesting in this module are addressing aggression and predictors of violence. This is essential for personnel to watch, and it's a great risk management tool as well, for sure. The second module deals primarily with drug treatment, chemical restraint issues, how marital relationships affect behavior. This is an interesting topic and one we don't often think about. And there's a great overview of the dysfunctional family dynamics and how do behaviors affect the staff and you. In the third module, Dr. Smith reviews and explains testing such as the mini-mental, the slums test, geriatric depression scales, and many others for your review. Pharmacological therapy will be explained in regards to mandated informed consents, and most interesting is the therapeutic windows of drug treatment. The final module talks about activities, and this is great if you have activity coordinators as well as the rest of your staff, and the prevention of mental illness using these activities. You're going to learn a great deal about the environment and non-pharmacologic interventions. These are the interventions we all look for and need in handling these challenging behaviors. Each module lasts approximately 1 hour, and you'll have slides addressing the objectives for each module, and I'm now going to share the required disclosures that we have to give you. So the program that you'll be seeing in 4 different modules is behavior problems, dementia, and mental illness in the long-term care setting. If you have cell phones or pagers or any other distractors, turn those off now so you can actually enjoy the series. As we told you, our presenter is Dr. David Smith. And this is approved for contact hours, and you must take the entire program. You're required to sign in, and you've done that by registering online. You'll be required to complete an evaluation and a post-test at the end of the program. Your evaluation sheet and post-test are required before you can receive your certificate. So now let me share the disclosures quickly with you, but there were no conflicts of interest evident in the development of the content for this activity by the planning committee members or presenters. There's no commercial support that was received by EMTI at Morningside Ministries for the activity. There are no endorsement of products, and there's no off-label use that's related to the content of this activity. What's great about the programming through mmlearn.org is if you want to ask a question or make a comment, you can do that. And if you want to send us an email, just click on the email, and I will tell you that you usually get a response within about 72 hours or shorter. What do you think? We always want to know what you think, and so at the top of your screen you're going to see this request for survey. We ask you to fill those out so that we continue to bring these programs to you. Remember, it takes less than 5 minutes. And the objectives, as I told you, for each program will be listed prior to the start of each module. So thank you very much. Enjoy and let us know what you think. Thank you. Bye-bye.
I want to segue now to behavior problems in long-term care and the assessment process, testing. Before we get too far into this, something that we don't do a lot of and probably should do a lot more in long-term care is formally assess mental capacity. And there is more than one kind of mental capacity under the law in the United States. There is decision-making capacity for personal decisions, medical decisions, and financial decisions. It is very common for elderly people to have an advance directive like a durable power of attorney or a power of attorney, not without the durable word on it, or not to have anybody named, and for a family member to step forward and become the decision maker and for the caregivers, the treatment team, the doctor, the nursing staff, to just do whatever that person says and not to allow the elder to make their own choices and preferences in treatment. This can even be as important as, should I stay in the nursing home? I don't want to be here. I don't want to, but Mom, you have to be here. The doctor says, but Minnie, you have to be here. The nurses say, Mom, Minnie, you have to be here. You can't take care of yourself. No, I don't want to be here. If that person is mentally capacitated under the law, us forcing them to stay in the nursing home is illegal. It could be prosecuted under the intentional tort of false imprisonment. The patient may be making, the resident may be making a bad judgment in saying, I don't want to be here, I want to go home. That may be a stupid decision, but if it is a competent decision, it is a legal decision. This is a hard concept to get our minds around, but competent people don't necessarily make the right calls all the time. I've invested in the stock market. 2 years ago, it became painfully clear to me that I had not made all the right decisions. But that didn't mean I was not competent, or that those decisions weren't legal decisions, and that the contract for owning those stocks was not a binding contract. And so if Minnie wants to go home and she really can't make it at home, but she is competent, she can go there and she can fail. Her insistence on going home and making a bad decision does not automatically call her family into the responsibility of shoring her up and making her a success in there. They may wish to do that, but they don't have to. And so sometimes we need to let residents fail in order for them to make the right decisions, and capacity is not necessarily, certainly is not always linked to correct decision making. When a resident is not mentally capacitated, then we go to properly to a surrogate decision making process, and if the resident has already named a POA, that POA may be written up as a contract that says that this person is going to help me with decisions and is going to act in on my part in doing a real estate contract over in Florida because I can't travel over there, so I'm sending you to do it. When the person becomes incapacitated, that POA goes away, and that person is no longer the legally recognized surrogate decision maker. If it's a durable power of attorney, then the patient has chosen that person to make their decisions on their behalf, both before they lose capacity, and that should endure after the person has lost capacity, and in fact becomes even more important for that other person to step in and be the official decision maker. If the individual has not named anybody, Texas has a law that lists a hierarchy of family members, starting with your spouse and moving down to your other family members, and a hierarchy that you go to for the person who is reasonably available to become the responsible party and make decisions on behalf of an individual who is not mentally capacitated but has not had an adjudicated instrument to take over their decision making. Testamentary capacity is capacity to make or change a will. This is a different standard in the law than decision-making capacity, and actually is a lot easier. You can be incapacitated for decision-making, but capacitated to have testamentary capacity if you know who your heirs are, your potential heirs are, and you know the extent of your bounty. That is, you have a general idea of what you have to give away when you die. It is not required that you know this exactly and that you be running on all four wheels in terms of being able to do the arithmetic. But you should be able to understand that if you got two kids, you can't give one of them the farm and the other one the old antique car and think that you're treating them equally. Okay, that would indicate that you're not having testamentary capacity. Finally, there's another type of capacity, and that's capacity to stand trial. And this, you would think, doesn't matter to us in long-term care, but it does. Capacity to stand trial also defines whether an action on the part of an elder is a crime or not, and whether you, as a witness to the crime, should report it to the law or just handle it within the nursing home as the action of a demented elder. If a person can have dementia and still be capacitated to stand trial, ergo potentially be able to commit a crime, and you have the obligation to call the law. If the individual knows the difference between right and wrong and has the ability to participate in their own defense, then they have capacity to stand trial and therefore capacity to commit a crime. If you have that circumstance, you are legally bound to make a report to law enforcement. If, let's say, there is unwanted touching, it is likely that the police will investigate, say, well, they're in a nursing home, and they'll turn it over to the DA, but the DA will decide not to prosecute it, and there's selective prosecution, and that's all well and good. But if you don't turn it in, you are at risk for some criticism and potentially penalties for not making the report. And be aware of that. We also have requirements to report things to dads when there are incidents that occur between residents, whether they are capacitated or not. Quantifying and following the cognitive deficit. There are a couple of instruments that I'd like. There are many instruments out there, but I'm going to recommend a couple of them to you. I bet that you are familiar with the MMSE, the Mini Mental Status Examination, which is a nice instrument. Doesn't take too long to do it. It doesn't take a lot of training to learn how to do it. And it is very good at discriminating across the spectrum of mild, moderate, and severe dementia, and separating dementia from not dementia. The MMSE, though, is not very hard. And so it doesn't stratify very mild cognitive deficits very well, including minimum cognitive impairment, which is not yet dementia, but might be on their way to being demented. And it doesn't stratify mild and moderate very well. It tends to stratify severe better. So an alternative instrument that I use a lot is called the St. Louis University Mental Status Examination, mnemonic SLUMS. And it does stratify normal from MCI from dementia, and is not very good at stratifying mild, moderate, and severe dementia. It tells you more or less demented or not, and it's pretty bad or it's not very bad. Another advantage of the SLUMS is that it's not copyrighted. I think very few people do send a buck or whatever it is back to the authors of the MMSE, the copywriters, but you're supposed to each time you use it. And the SLUMS actually was written by a professional friend of mine up at the VA up in St. Louis, Missouri, who has actually just donated this to the world. It's for the public to use with no kickback or remuneration to him. There is an instrument out there called the confusion assessment method that is widely used across all care settings, has actually various variations of it for the ER, for the ICU, for the hospital, for the long-term care environment, and it's called the confusion assessment method to evaluate for delirium that I refer to you. The Beck Depression Inventory and the Hamilton Depression Scale are particularly useful instruments to evaluate for and follow the progress of treatment, the efficacy of treatment, when dealing with major depressive disorder. Those are best used in people that are under the age of 65, and obviously in long-term care we're starting to see more people that are under 65, so be aware that those are available. The Geriatric Depression Scale comes in both a long and a short form. There's really not much advantage to using the long form. The short form is just 15 questions, and it stratifies or discriminates depression from non-depression just as well as a long form. This is a series of 15 questions that we give to patients without dementia, or those with dementia up to the moderate stage. The break-off on an MMSE is at 15. If they are above 15, they are mentally able to understand the questions and give you reliable answers. You can use the GDS to assess their depression or their depression treatment. If they fall below 15 on an MMSE or below the mid-range on a SLUMS for dementia, then you're probably best off to go to a Cornell scale, which is a caregiver rating scale over the past 2 weeks, the behavior that the resident has shown, the characteristics of their clinical case over that 2 weeks. And this does not require any input from the resident, so the resident can be nonverbal, non-communicational, and you can still make a putative diagnosis of depression using this instrument. There are other instruments out there, the CESD, Center for Disease Control Depression Scale, which is reported to be better for those with other than the typical American culture. So there are some special scales out there. Another one I want to refer to you is the mania scale. Mania can be found in those patients with uncontrolled bipolar disorder and euphoria, the mania side of the disease. But mania can also occur with brain damage and with other organic brain syndromes like the dementias. And the mania scale rates this also not by resident interview, but by the caregiver rating scale that is done over your experience with the resident during the past several weeks. I want to point out to you a scale called the functional pain scale. Now, that's not really behavior, that's about pain, but wait a minute. A certain number of our residents are handled through the MDS process, and the input to the data, the MDS 2.0 and now 3.0, is by resident self-report of pain. I bet you there's not one person in the audience that hasn't had a resident who we believe doesn't have real pain and is instead a a narcotic abuser who resides in the nursing home. These people are not in pain, or if they are in real pain, they are embellishing their pain in order to receive drugs for recreational or addictive purposes. And that makes their pain complaint untrue, and it makes their pain complaint a behavior and not part of the pain documentation. And that's what the MDS process has not yet dealt with. And we really need to do it because, well, I just agreed to take a patient at one of my local nursing homes who is adjudicated mentally incompetent because of narcotic addiction. And she came to me on 4 different Schedule I drugs. Now, there is no scientific reason for that. She's receiving 4 different Schedule II narcotics that I have to do, that I putatively will have to do triplicate prescriptions for, and that ain't going to happen. The functional pain scale does not rate the patient's pain with the smiley faces or the 0 to 10, which is totally their interpretation of their pain. It's just whatever they say it is. And the way the MDS process is, you're supposed to take that on face value. And every pain textbook that I pick up says that the first rule of pain management is to believe the patient's pain complaint. Now, that's actually true even with an abuser, because when you give a narcotic to a patient who has pain, their function improves. If you believe the patient's pain complaint and give them the narcotic, their function improves. If you believe the patient's pain complaint in a known narcotic abuser, you are not being naive, you're not being a pushover. Instead, you're in a diagnostic period of handling that patient in the beginning, and you give the narcotic and the patient's function does not improve. It either stays the same or it gets worse because they are becoming inebriated. And now you have objective evidence that the patient is not experiencing pain and instead is misusing the narcotic. Without that, you can make a big mistake because there are such things as pseudo-addicts. There are people that have been labeled as addicted, and the reason they're labeled as addicted is because nobody believes their pain complaint, and they've been getting subtherapeutic doses of narcotics, and they get a tease of relief, but they can't get all the way there, so they start going from one doctor to another doctor, lying, cheating, whatever they can do to try to get a full measure of relief. And I had one of those a number of years ago, and when I believed his pain complaint, I didn't emotionally believe it. I thought he was working me, but I followed my rule. I believed the patient's pain complaint. I gave him a narcotic. He came back. He wasn't any different. He wanted a higher dose. Well, I thought I was getting worked, but I stuck with my rule, believed the patient's pain complaint. He wasn't worse, so he hadn't proved himself to be an abuser. I increased his dose. When he came back, he said, well, it's not good yet, but it's better. Now, narcotic addicts don't tell you that. And his wife was there, and he said, yeah, he's moving around a little better. He doesn't groan as much. You know, he's acting a little different. And so I upped him again. And the next time they came back, she said, my gosh, what did you do? He's out in the garage building birdhouses again. He hasn't done that for years. This was a guy who was trying to achieve pain control and couldn't get there because nobody believed him. That's a pseudo-addict. This patient that I have now, I fully expect that when I go through this process, I'll give her an increase in pain medicine, although I'm going to consolidate it down to one drug. And what's going to happen is her function will deteriorate. And I will now have objective evidence that she doesn't have pain, that she is misusing narcotics, and I can approach that in a behavioral way. The functional pain scale doesn't just accept her notion of what her pain is. These people will tell you their pain is 10 every time. What the functional pain scale is on a 0 to 5, and the 5 is pain is defined as pain that's so bad you can't talk to me. You walk out of here and you get hit by a bus, runs over your legs, and I run out there and say, are you in pain? You're not going to say, yeah, it's a 5, okay? You're going to be screaming your head off. So that's a 5. So you tell the patient tries to tell you it's 5. No, it's not a 5. I'm not writing that down. The definition of a 5 is you can't talk to me. Okay, then it's a 4. Nope, I'm not accepting that. A 4 is pain that's so bad that you can't watch TV, you can't listen talk to people on the telephone, you can't listen to the radio. You've been doing that all afternoon. So I'm not writing down a 4. Oh, okay, it's a 3. Okay, I look down here. A 3 is pain that's so bad I can't do quantum physics, I can't play chess. Okay, so I'm going to write it down. It's a 3. And I can force people back into a more correct assessment of their pain using the functional pain scale. Hamilton Anxiety Scale is a good scale for anxiety. There are others. And the last thing on here without a bullet sign on it is just a book that I highly recommend to you. It's got, I don't know, must be 150 different assessment tests for every possible thing you can think of in the arena of psychology, psychiatry, and old age. Well worth the bucks. Just about every one of those tests in there has a website you go to, and then if some of them are free, other ones you have to purchase the test in order to use it. I wanted to give you another method of objectifying the nursing assessment of behavior problems. Many times you'll be able to take a problem behavior. Mr. Schwartz is streaking out in the hallway without his clothes on. That's our problem. Well, how many times a week does he do that? He does it 8 times a week. We watched him for a while. He's doing it 8 times a week. You give him medication. He's now doing it 4 times a week. Is it working? Yeah, it's working. Just not good enough. No side effect. I can up the dose. So I up the dose, and now he's down to only once a week. So that's good. Has he got any side effects? Well, yeah, he's showing a little bit of side effects. They're not too bad. So I try to crank up the dose again, and make the frequency of the behavior 0, and the behavior doesn't extinguish, or maybe it does, but the side effect load is too bad. So I go back one step. I back titrate to where I was before because it's the happy medium between efficacy and side effects. I've done that based on an objective measure. How many times does that behavior occur in a period of time? Some behaviors are too complicated, variable in order to do that, and so or they occur so often that trying to tally up the numbers of times, how many times they do it a day, 100 times a day, that's not going to be very, user-friendly for the nursing staff. So another way to do this that we have found is to use the pain scale and apply it to the nurse. And so you ask the nurse and the aide staff to rate their pain as a caregiver in taking care of this patient with a behavior problem of such and such on a 0 to 10 scale. How hard was it for you? How objectionable was it for you to deal with this resident? And then we need them to initial their score, because the frequency and the severity of the problem is in the eye of the beholder, isn't it? If Mr. Schwartz is streaking, getting naked and coming out in the hallway, and the nurse had 4 brothers when she was a little girl, doesn't bother me very much. If the nurse is maybe a little on the prudish side and hasn't had that experience, then, oh my God, see it just once, and it's awful. It's the worst possible thing that could happen. So the behavior is a lot of it in the eye of the witnesser of that behavior, and we don't want, as the treater, to be colored by their perception of the behavior. We want an objective measure. So we need them to initial their scores so that we can see one person's differences from another. That's called inter-rater reliability. Now, I'm going to give you a case here. Minnie has delusions of a parasitosis, this is called, delusions that worms are crawling out of her skin and out from under her fingernails. This is a real case. She's scratching herself raw and complains constantly of the worms to the staff. Just eating up their time, and what can they do about it? It's very frustrating. So before we do anything, we measure the baseline of her behaviors, and we ask the nursing staff, how tough was this for you to deal with on your particular shift? Make your pain score and put your initials. And we get, on a number of shifts, we get 7, 10, 8, 8, 7, 6, 10. Then we go ahead and we initiate a drug for an antipsychotic, because we think this is a psychotic delusion. And we get it going at an ordinary starting dose, and we wait for it to reach steady state, and then we do another look at the objective measure. And the numbers we get from the nurses are a 10, 7, 8, 6, 8, 10, 7. By the way, there were no adverse drug reactions. Does this score, this series of scores, look on average any different than the pretreatment baseline, Karen? Doesn't look like anything happened, does it? This medication at this dose ain't cutting the mustard. But there were no side effects, so let's crank it up. Let's give it a twist, upwards, up titrate. So then we do that and wait for that to give it time to work, and that's very different for different drugs. And so then we get a 7, 8, 10, 8, 10, 6, 7. What do you think? This ain't cutting the mustard. There's no adverse drug reaction, but we're suspicious. We're getting up to high doses. We don't think we want to go on. Or maybe there was a little drug reaction. We decided not to go further on titrating. We decided to change. So we changed to a different drug, and after the appropriate time for it to reach its steady state, we look at this again. We got a 6, 8, 6, 5, 7, 7, 5, 6. There's no adverse drug reaction. What do you think, partner? Is this person better? Is Minnie better? Looks like there's a little hint of improvement here, isn't there? It's not great, but there's a hint of improvement, and we didn't have an adverse drug reaction, so what do? Well, it's pretty obvious. We're going up on this dose. That's how we use these numbers. We need to use these scales. We need to have trained interviewers, raters. For each test, you need to read the material. How do you do this? How do you ask if you're asking patients questions, you need to know how to ask the questions so you're not helping them and you're not making it difficult for them to get the right answer. You're trying to be neutral. But the good news is that this testing business is not all that hard. This can be taught to ancillary staff, to good bona fide nursing staff. We can develop a culture or a protocol where we let various MDS items or groups of items trigger automatically an assessment. You know, on the QIs, one of the QIs is signs and symptoms of depression in the absence of antidepressant therapy. Well, why not make it so that anybody that triggers that in the Songbird Lodge automatically gets a geriatric depression scale or a Cornell scale? That's not hard to do. Let's just, every time that series of items gets triggered on an MDS, let's go ahead and run the assessment instrument, see if they're actually depressed. Or maybe they're triggering that list of things because they've lost weight and had poor appetite, and they're not depressed. Well, then we figure out, hey, they're not depressed. It's because we started amiodarone and it's killing their appetite. Okay, so we get to the right answer, whether it was behavioral, psychiatric, or not. We want to trigger from any identification of a potential problem also by a team, by the team itself or by any team member. So if the aide comes to us and say, boy, something's changing with Minnie, she's getting really down in the mouth, or let's say the PT lets the doctor know, can we please discontinue therapy on Minnie because she's not participating. I actually have a rule in the homes where I work and a medical director that the therapists may not ask for orders to discontinue physical or occupational or speech therapy for non-participation unless the patient has been assessed for depression. Make sense? It's absolutely required that we do that, and yet we haven't made it part of our system. We need to set a time to retest people using the same scale when we initiate therapy in order to reevaluate the efficacy of that therapy. We just saw that done 2 slides ago with the nurse ratings of Minnie's worms. When would we reassess? Well, we would reassess at the point in time when we would expect the medicine to have been given long enough to have had a chance to work. Different medicines have different times to effect. That's based on the elimination half-life. We'll talk about that in a little bit. But there'd be no point in us checking again after 1 day if the medication we gave takes a week or 3 weeks or 4 weeks, in the case of an antidepressant, 3-4 weeks to kick in. And so if I have ordered a medication like, or I've ordered an antipsychotic for assaultiveness that I believe is due to psychosis, and I get a call 1 day later and the nurse is screaming on the phone for me to do something else, she just whacked on so-and-so again, my answer is no. I made my intervention yesterday and it hasn't had time to take effect yet. We need to objectify what is poorly handled by subjective assessment. We need to get rid of problems with inter-rater reliability, and let's not be doing this by the seat of our pants. We would never treat hypertension without measuring a blood pressure. How would you know whether the blood pressure medicine worked? And we need to do the same thing with behaviors. Now, on these assessment scales, question is, and I can't answer this one for you, it depends on the culture in your particular home or institution. Do you need a doctor's order to do a geriatric depression scale or a Cornell scale? I don't know that you do. You don't need a doctor's order to do a Braden scale to look for their risk of developing a pressure ulcer, or you don't need one to look for their risk of elopement. So why would we need to have a doctor's order for a test to evaluate for the chances that somebody is depressed, anxious, psychotic, manic, etc.? I think these things do not require a doctor's order. Let's move on now to pharmacologic therapy. The drugs we use, and since many are not doctors, you won't need all of the nuances of dosing and so forth, but nevertheless you should understand what these drugs are used for, what they're not used for, why we use them based on their mechanism of action. Cholinesterase inhibitors are medications that are used putatively to enhance cognition, although they very seldom do that. Most of the time, what we expect from drugs like donepezil, rivastigmine, galantamine is a slowing of the inevitable decline that occurs with Alzheimer's disease and related disorders. Tacrine is on the list, although it's rarely used. It's still available. But Tacrine was the first drug to come out, first cholinesterase inhibitor, and unfortunately it had a load of side effects, most of them liver problems, and it was a 4 times a day medication. You'll notice these others are either once a day or twice a day medications. A 4 times a day medication for memory is just not a real good concept. So that one didn't last very long. The NMDA inhibitors class has only one member, and that is memantine. And these have randomized control trials that show evidence of efficacy as I've outlined it. Now I want to throw out to you a very simplistic grid for the treatment of dementia and psychiatric disorders causing behavior problems in elders, and this is not hard and fast. There will be variations on it. There will be hard cases in which people do things that are off-label or different than this, but by and large, for 90-some% of the cases we see, this is the appropriate treatment choice or choices for these conditions. When people have cognitive problems, it's appropriate, as I've just outlined on the previous slide, to use a cholinesterase inhibitor or memantine. If people are depressed, it's pretty obvious that we should use an antidepressant. If they have depression with psychotic features, it would be appropriate to use an antidepressant along with an atypical antipsychotic. If they have a delirium, we try very hard not to treat it with drugs because drugs generally make matters worse, but when we are forced to, by the consequences of behavior or comorbidities, physical comorbidities they have, then we would expect to use either a rapid-acting atypical antipsychotic or the old-fashioned haloperidol. Haloperidol comes with a load of potential movement disorder type side effects, tardive dyskinesia and extrapyramidal side effects, but generally speaking, those things occur with extended use of a typical antipsychotic and with high doses of a typical antipsychotic. And if we're treating delirium, the treatment is expected to be very short-term and probably at very low doses. Not to mention the fact that haloperidol comes in all different dosage forms. You can give it IV, IM, you can give it as a PO, as a liquid, or as a pill. And so the options are there. That makes logistics pretty easy to deliver the drug. Finally, it's dirt cheap compared to the atypical antipsychotics, which are all $4 signs when you look on a formulary. When we have psychosis in the elderly patient, we do expect to use an atypical antipsychotic. So you'll see the AP listed 3 times here. And even though these are expensive, when we are going to be treating long-term and may potentially get into higher doses, it is wise to avoid the movement disorders that are common with the extended or higher dose use of a typical antipsychotic. The worst of the movement disorder problems that we see with this from the standpoint of medical legal issues and medical consequences is tardive dyskinesia. Tardive dyskinesia happens when we use typical antipsychotics for long periods of time in affective disorders, people with mood disorders, bipolar, and depression, when they have an organic brain syndrome, such as a dementia, more often in females and more often in the elderly. So, I've just described the poster child nursing home patient, and that means nursing home patients are at very high risk. Tardive dyskinesia oftentimes will get triggered if they have some dental problem, or heaven forbid, if they have a change in their dentures or new dentures. It will trigger this consequence of a movement disorder from an antipsychotic, and they'll develop the lip smacking, the grimacing, some of the horrendous torticollis kind of problems that you see with this that can be so socially disabling. And the tardive dyskinesia can also manifest as dysphagia and lead to aspiration pneumonia. So we want to try to stay away from that as much as we can, except when the use is expected to be short-term and at lower doses. Continuing the treatment grid for dementia and other psychiatric disorders comorbid with dementia in long-term care, when we have mania with or without bipolar illness, we want a mood stabilizer. Now, lithium is very, very effective in this category of illness with younger people. It would be effective in older people, but it becomes increasingly dangerous because of fluid electrolyte issues, renal issues, thyroid, and even cardiac issues. And so generally speaking, lithium is not a preferred drug in this age group. And if we use a mood stabilizer, it's most likely to be valproic acid. There are a variety of other antipsychotics that have also been used, gabapentin and so forth. Chronic anxiety disorders, and I emphasize chronic, is not best treated with benzodiazepines. It's best treated with selective serotonin reuptake inhibitors, albeit not in the same way that we do it when we treat depression with these drugs. Typically, when you're treating chronic anxiety with SSRIs, as a matter of fact, using the drug initially can increase anxiety because it hits some of the serotonin pathways in the brain that stimulate anxiety before it gets to the pathways that inhibit anxiety. And so you want to treat chronic anxiety disorder with SSRIs using lower doses to begin with and making lengthier times to titration upward as you go along. And potentially, if the anxiety disorder is lifelong, you'll be using the drug forever, while in depression you might use it for a time-limited period. The other drug that we can use for chronic anxiety that is oftentimes forgotten is a drug called buspirone. Buspirone got a bad name because when it first was marketed, first came on the market, it was thought to be an appropriate trade-off for long-time use of benzodiazepines. But we now know that people that have been on benzodiazepines for a long time have messed up their GABA system, and the buspirone is not going to work for them. So you only want to go to buspirone when the person has not, when they do have a chronic anxiety disorder, but they are naive to benzodiazepines, at least have not used them in large doses for long periods of time. If we have acute or situational anxiety, something we expect to treat for just a short time, then using a benzodiazepine is appropriate. But these drugs are potentially dependency causing or addicting, and they increase the risk of falls, particularly when they are long-acting. One of the over-regulations is you may not use long-acting benzodiazepines unless short-acting drugs have been tried and failed. Short-acting drugs, when you look at them statistically, don't really increase the risk of falls, and yet probably they do, but they only do it during the short period of time that they're active. And you take a drug like a lorazepam, and it's only in and out of the bloodstream for 4 hours. So it's pretty effective without creating a lot of risk for the falls. For those when we do use benzodiazepines, we prefer those that are short-acting. And the shortest acting are, as I said, lorazepam and oxazepam. The brand name for lorazepam is Ativan. That for oxazepam is Syrax. And not as popular, but there's not a lot of difference between those two, so I'd go for the cost. Both of those drugs also only require phase 2 liver metabolism, which is pretty much okay in everybody, regardless of their weight and regardless of their liver status. That's not going to be too big of an issue. It's when things need CP450, phase 1 liver metabolism, that you may not be able to trust the effectiveness of their metabolism in the elderly or in those with liver disease. Appropriate chemical restraint. We did that on a slide earlier. When you're using something to sedate the person long enough to get your team pulled together and figure out what your real care plan is going to be for this behavior, and when the behavior is a real risk to the safety of the elder or others, then it may be appropriate to use chemical restraint for a very time-limited period. And the drug of choice, in my mind, would again be a short-acting benzodiazepine with only phase 2 liver metabolism requirements, so oxazepam or lorazepam. Those drugs being very short-acting, you can start with a very low dose like lorazepam 0.25, and it's going to hit the bloodstream and be active within a half an hour. It works and it is absorbed just as well orally as it is IM, so the only reason to give it IM is if the patient refuses to take it PO. And you'll know after only one dose whether you guessed right on the dose or whether you need to crank it up. And you could crank it up at 0.25 milligram increments until you get to a maximum of 2, and give it no more often than every 4 hours. I think that you'll capture and get sedation and chemical restraint style of behavior control in almost all residents within that dosage range. Now, we don't use chemical restraint as a permanent treatment plan. We can use it when the person is a danger to themselves or others, and use it as a temporary intervention until we can find what we really should do for this problem. We might also use it before dental work, before a minor operation, even before an examination, like let's say maybe a pelvic examination in an demented elderly person who we thought might have placed a foreign body into the vagina. Drug treatment and titration issues. Before we choose a drug, before we deliver a drug, we should put ourselves on the spot to determine what are the target symptoms. Now, I previously said to you, we don't use drugs to extinguish symptoms. We need to use drugs to correct what we think is wrong with the patient in terms of a psychopathology, neurochemical and neuroanatomical problems in that brain, which are then causing a behavior. But we can't, once we've done that, we can use the behavior, the number of times, the severity of it, the nurse's rating of their problem in caring for it, using that objective evidence as a measure of, is the drug working? That's what I mean by determining target symptoms. And so if the patient is depressed, we're going to treat their depression. What are we going to measure? Well, we're going to measure that Cornell scale or the GDS, but we're also going to look at their appetite because they weren't eating well. We're going to look at their sleep because they had lousy sleep maintenance. They were doing okay with sleep onset, but lousy sleep maintenance. We're going to look at their participation in activities and in therapy because they were amotivational. So those are the target symptoms that we throw up to ourselves to determine in a very practical way whether we've done any good for the resident by giving them this drug. And we should do that prospectively because we need to put ourselves on the spot. We can't define success after the fact. That's cheating. I told you about mandated informed consent in this neck of the woods in Texas. That is the law. There is also a thing called the therapeutic window I want to make you aware of. When you start a medication, in theory, there is a dose which isn't enough to cut the mustard. It isn't going to work. As you increase the drug, it's going to start to work, but it's not working suboptimal. It's working suboptimally. It's not at its full effect. You continue to increase the dose until you find the perfect dose that does the most good. If you continue to push the dose up, you turn the corner and you start to go back down with virtually all drugs, and you start to lose efficacy when you go to supratherapeutic doses. And that's why it's important to make your titrations, your up titrations, at a timing that matches How long does it take that drug to reach its steady state in the body, to reach homeostasis, a blood and tissue level that stays the same between doses as you continue to dose the person? This is why some drugs are once-a-day drugs and some drugs are 4 times a day drugs, because it has to do with their elimination half-life, and you're trying to achieve some kind of a steady state, a permanent level of the drug in the bloodstream and particularly in the tissues of action. So time to steady state needs to be known. Usually, for practical purposes, you can look in the PDR or your other drug reference for the elimination half-life, the E1 half, and multiply that number times 5, and that will give you the time that it takes to reach the steady state. It's also the amount of time that it would take to stop the drug and to have it putatively be virtually all the way out of the body. So that's the way to use the E1 half number, multiplied times by 5, and you've got a useful number in both directions, retitrating a drug or stopping a drug and knowing what you've got. Again, we need to do that objective symptom monitoring and match that to the time to steady state in order to know where we are. If you get pushed, as a prescriber, if you get pushed by your nursing staff to aggressively up-titrate because the behavior is problematic, you can blow right by the therapeutic window and never know that you got the right choice of drug and end up back over in this spot where there isn't good efficacy or there are side effects. And you had the opportunity to get the right answer, make the person well, but you moved too fast, you didn't give the medicine time to reach steady state, and you missed the boat. They call the patients patients because they're supposed to have it, but I think sometimes the nursing staff and the doctors need to have patience too. We need to monitor for adverse drug reactions, and the ideal time to do that formally is again at those times to steady state with each dosage titration, but certainly we can be alert to that all the way through therapy. And I'm pretty proactive about this. When I write a psychotropic drug, I usually write down, if I know the nurses don't know it by heart, I write down what adverse drug reactions I really especially want them to watch for. So if I start mirtazapine, I'll start it at a test dose of 15 milligrams for 2 or 3 nights and make sure that the patient doesn't have orthostatic hypotension when they get it before I go up to 30. When I do that, I ask the nurses to observe for signs of orthostatic hypotension during those first few days and to report to me. If you write for an antipsychotic, I think it's reasonable or wise to either have a policy and procedure in your nursing home to do the Ames test, to look for movement disorders at 3-month or 6-month intervals, or to write an order to do so. It's the same thing as if you started a drug for cholesterol and you would tell the nursing staff to check the cholesterol every 3 months or 6 months, and you would also tell them to check the liver enzymes to make sure there's not liver toxicity with that statin drug. So we need to apply those rules of going to our psychotropic drugs at least as religiously as we do to the other drugs we use. When we decide to do a gradual dose reduction and to discontinue, or whether we decide to plan for lifelong treatment, should also be decided when we start the drug. We might modify that plan later on, but it's appropriate and proper for us to make that decision right up front. And given the law in Texas, we actually have to give that as part of the informed consent to our patient, our competent patient, or to our responsible party who's going to approve the use of the psychotropic drug as one of the requirements of the law. And we need to do that consistent with CPG's here on this slide stands for Clinical Practice Guidelines. The American Medical Directors Association has a number of these that are relevant to psychotropic medications, as does the American Psychiatric Association. So I'll give the audience here a little task. Most of you are remote on a videotape, so you are hearing this long after I've said it and can't answer me, but in your head, define, if you will, what is appropriate chemical restraint and what isn't appropriate, what's inappropriate chemical restraint. And the hint, of course, is to remember your OBRA guidelines. Well, appropriate chemical restraint is temporary use while you're getting your act together to figure out what your long-term care plan will be for problematic behavior in the elder. Or use temporarily when the individual is a legitimate danger to self or others, again, awaiting a more permanent care plan. Or when there is an identifiable rare but recurrent event like dental care, a medical examination that's noxious, etc., that you know is going to cause problems for the elder, and you want to prevent that experience, and you may properly chemical restrain them. Otherwise, it's inappropriate. And it's always inappropriate when it's for our convenience to sublimate a behavior without actively treating the underlying pathology. So again, a task regarding chemical restraint. What's wrong with this order? Haldol 0.5 to 1 milligram PO orally or IM intramuscularly, Q4 hours, PRN agitation, telephone order, Dr. Ronald Jones, transcribed by Brucella Bruce, RN. What isn't wrong with that order? All right. Well, it might be wrong, but it might be right to use a typical antipsychotic instead of an atypical one because of the movement disorder risks. But it might be all right, especially if this is short-term, low doses are used, etc. What about giving a dosage range like this, 0.5 to 1? How's the nurse going to decide? Decide by what factors? This is not okay. This is not tight enough in terms of what dose. Is it wrong to give the order PO or IM? Well, probably not, although I would have liked to have seen a little guidance that PO was if the patient is okay with it, and IM if they're not, but we can only give it against a resident's objections, even if they are incompetent, in an emergency situation where the resident is a danger to themselves or others. An imminent danger in Texas. In some states, the standard is danger to self. In a very few states, the legal standard is need for treatment. I think 23 states have a much more permissive attitude towards this. But in our state, it is imminent danger to self or others. And without that, even an incompetent resident could refuse an antipsychotic. And this order skirts that issue and tends to authorize the nurse to give this against a resident's will. Every 4 hours as needed for agitation. What's agitation? There's another criticism I have. We haven't defined what is agitation. Is this agitation coming up to the nursing station and bothering us while we're trying to do our other work? Oftentimes that is the definition, but that won't meet the test of danger to self or others and would not allow us to give this medication. It would be a chemical restraint. There's maybe nothing wrong with this being a telephone order, but 3 days or so later, if there hasn't been a concerted effort of the treatment team and the physician to deal with this in a more orchestrated way using interdisciplinary teaming, then potentially this is a bit cavalier to be a telephone order. So OBRA says to maximize the resident's physical and mental well-being or slow inevitable decline. And my algorithm, my pathway for use of medications, drug or treatments of behavior problems is to fully define the behavior, to develop a diagnostic hypothesis, and then based on the diagnostic hypothesis, not the behavior, to craft a drug and or a non-drug therapy to fix that or to help it. Now, OBRA language kind of implies that you have to use non-drug therapies before drug therapies are used. That's actually, I'm going to take issue with the law. It's not a good law in that regard. And for some mental conditions, for true psychosis, a drug therapy is required. And monkeying around with non-drug therapy would be wrong. To wait for it to fail when you know it's going to fail. If the person has paranoid delusions coming out of paranoid schizophrenia, it would be nonsensical not to get going on a drug treatment and treat that before somebody gets hurt. For most conditions in long-term care associated with only dementia and no other comorbidity, non-drug therapy would be the mainstay. And we really ought to use it before and probably always in the absence of a drug therapy. If we did give a combination of the two, the drug therapy would be augmenting the non-drug therapy. But in the case of true psychosis, serious depression, other mental disorders, bipolar illness and so forth, drug therapy is the major player, the sine qua non of treatment. And non-drug therapy, while valuable and a necessary part of each regime, would be the add-on or the augmentation part of the care plan. So this is not an either-or choice, as sort of implied by the OBRA language. Follow-up needs to be by objective symptom monitoring, measuring target behaviors before and after treatment at the steady-state intervals, and using the objective measures in a way that nullifies inter-rater variability. And finally, we need to systematically follow up on side effects, overall function, and the length of treatment. There is evidence-based data to show that cholinesterase inhibitors are valuable for cognition. Again, I said it's mostly to prevent inevitable or to slow inevitable decline. People don't usually get better. It is important to recognize that you probably can't tell whether the drug is working in an individual patient. You really have to look at populations of patients being treated and compare that to people that are untreated in order to see that the outcomes in the treatment group are better than the outcomes in the non-treatment group in order to determine the efficacy of these drugs. But if you look at the marketing claims for the various cholinesterase inhibitors, you'll see that they make claims for improving behavior. And I think that's greatly exaggerated and should not really be thought of that way. Do I think of these as being useful in the arena of behavior problems in dementia? Sure I do. But the way I think of it is that it's best to maximize cognitive functioning as a requisite for the most normal behavior you can get. Not that this is going to fix any abnormal behavior. The same thing would be true for Namenda, Memantine, the brand name Namenda. If you look at their marketing literature, they make a claim and they have some quite weak, it's positive, but some quite weak data indicating that people that are treated have fewer behaviors, less severe behaviors, longer time to the onset of first problem behaviors in dementia with treatment groups as those without. Again, it's about cognitive function, and it's not a behavior-modifying drug per se, as we would think of the psychotropics. By the way, there are some treatments out there in the lay literature and even in some in the medical literature, and things that have been debunked as not having a significant effect in dementia are ginkgo, vitamin E, estrogen, selegiline, the nonsteroidal anti-inflammatory drugs, and chelation therapy.